Chairperson, ladies and gentlemen, we have this session on left-main PCI, and I am being given this responsibility of doing coronary. I am given responsibility for doing the coronary imaging during the PCI or planning of LMCA PCI by imaging. We all know that there is IVUS and OCT for imaging, and IVUS is phase array and rotational array with the increased high definition pictures, and various types of catheters are available. First we have to choose that, what exactly we want, and for OCT there is one only, but usually for LMCA PCI, IVUS is preferred for its penetration ability. So difference in the IVUS and OCT is penetration ability, more with the IVUS, less with the OCT, but for the surface, OCT is best, and for overall vessel, IVUS is the best. So if you want to look at the surface, if you have say ISR and you want to look at the surface in a greater detail, then it's better to go with the OCT. The significance, what we want to do before starting a PCI, before do a imaging, if lesion is tight, we have to dilate it first and then let the catheter go for the imaging with the IVUS and find out whether we need to do anything about it, whether lesion is significant or not. And angiographically ambiguous lesion, especially in the left circumflex, if the lesion is critical or not, because if it is not critical, only provisional stent is good enough. But if it is critical and significant, then of course we have to plan right in the front the two-stent strategy. So that determines the risk of distal embolization. If there is a lot of the lipid core is there, then of course distal embolization will be another issue. So coming to the significance of the left main, sometimes if left main is not looking critical, we can do the left main significance is not there or there with IVUS or imaging only for the left main, not for other epicardial arteries, and as it correlates well with the FFR values. We can see the FFR value, it correlates well with it. And once it is less than 6 millimeters square, then it is critical and it correlates with the FFR value. Now, during the imaging, what we want to see, whether stent is optimized well or not, apposed well or not, is there a malposition, is there a dissection, and what we need to do, if calcium is there, before stenting, of course, the calcium is there, we need to select what kind of tool we need, whether we need a atherectomy tool or cutting balloon is good enough. So basically we see these pictures and IVUS picture and OCT picture. If you have a surface to be seen very clearly, sometimes you need to combine, in few patients, you need to combine both IVUS and OCT, especially if you are unable to gauge the calcium depth. Calcium depth is best gauged by OCT, not by IVUS. So once you define all that, then of course sometimes you can see whether this is lipid-rich plaque or not. Then it is better to avoid stenting at this stage, stabilize and do the plaque, because it will cause distal embolization, and it can be other side, if we can have a erosion or some other etiology. And then of course, is there a classical calcific nodule or not there? We can see a classically jagged edges of the surface of the, we can see the jagged surface of the nodule. This is the reason for it is thrombocalcific lesion. If thrombosis usually form and causes, this is third important cause of ACS, acute coronary syndrome. So there are both scoring calcium. For calcium, there is a score system to decide whether we need to do the atherectomy or cutting balloon is good enough based on the arc. Basically, arc is the most important criteria. If arc is more than 270 degree, we have to consider the atherectomy device. And currently, we are very familiar with ROTA, and usually ROTA is preferred in India and all over the world also. But there are other devices like available orbital atherectomy which can be considered. Or sometime even laser, depends on what kind of lesion, and particularly if it is ISR, laser is good enough. Then after the stent is deployed, we have to see whether it is expanded well, struts are properly opposed or malopposed. Is there a tissue protrusion, edge dissection, intramural hematoma or not? So if it is malposition, we can identify with the chromoflow, and we can see that there is a blood. You can see blood in between the stent and the wall of the artery. Or there can be a dissection, and there is a criteria to consider whether to put a second stent or not, depending on the degree more than 60 and the length more than 3 millimeter. So this is a calcium scoring image, and I have one example case which I would like to depict here, and that example case is of Lefman, critical Lefman involving distal bifurcation of the Lefman, and we can see that these pictures post ballooning are seen very well, and then we did a ROTA on this patient based on the arc, and after ROTA, culotte 2 stent technique was done, and we can see that here pre-stenting and this is post-stenting. You can see a very clear lumen, and with the LCX dimension more than L6 dimension more than 12 or 14.8 millimeter exactly. So we can have edge dissection. If it is on intimal, though, we don't need to do anything. If it is deep in the media and the angle is more than 60 degree, then of course we need to consider. And then of course this can lead to hematoma or even extramedia hematoma. And then stent deformation, we all know that when we do Lefman, sometimes inadvertently guide can suck in and can cause the longitudinal stent deformation. So we have to be careful. So this is the advantage of doing the imaging, and then various other reasons that we can consider in ISR with the OCT, and we can find out. So what is the advantage? Do we get any outcome benefit with the IVUS or imaging technique while doing a Lefman PCI? It has been classically demonstrated by 17 studies and 2 out of them as RCT with a meta-analysis. It shows that it reduces the relative risk reduction by 40%. And even it reduces stent thrombosis, myocardial infarction, target vessel revascularization. And the benefit continues to go on. 11,264 cases. This is the registry cases by British Cardiac Society, and it shows that as if you use imaging versus angio-guided PCI Lefman, we can see a clear-cut mortality benefit of 34% when you use IVUS guidance, and benefit continue to increase over a period of year. So it's important that for all Lefman PCI, we consider very important to do imaging, preferably HD IVUS, and LMCA PCI using intravascular imaging ensures optimal stent optimization, which reduces stent failure, improves acute and short-term, long-term results and outcomes. Intravascular imaging scientifically guides about the use of appropriate atherectomy tools or plaque modification tools based on plaque morphology characteristic provided by OCT or IVUS imaging, which allows the complete stent opposition, expansion, and provides higher MSA. Bigger the better for providing excellent long-term result, which improves outcome with mortality benefit. The biggest advantage is outcome continue to improve mortality benefit as the time passes over a period of years and decades. Thank you for kind attention.